So welcome to the third webinar in our data and measurement series, where we're exploring data and measurement in youth mental health, both here in Canada and also internationally. And so we're excited to have the first part of that international global conversation today in our third installment of the series. And really the first webinar that we had really talked about what we mean when we talk about data and measurement. And then the second in the series looked at Learning Health Systems 101. And today we're going to talk more about what, when we're talking about standardization of data and measurement tools, what might be missing from that conversation and that personal piece from that standardization conversation. So really excited to welcome Dr. Nicola Byrom to our series and to have this discussion today. I'll pass it over shortly, and then we'll have about 45 minutes of a presentation from you, Nicola, and then we'll go into some question and answers. So if you have, and a bit of a discussion, so if you have any questions during the presentation, please do put them into the chat right away, and we'll get to them near the end. And then also feel free to use the chat function as we go, and we are recording this session, which we'll be uploading to our YouTube channel, which is the last thing I'll say before I pass it over. And I will put that link into the chat for folks, since we do have the first two webinars up there already, and we'll add the third of the series after today. So without further ado, I will pass it over to you, Nicola. We can get started with this discussion today.
Thank you, Alyssa. Thank you for the introduction. It's lovely. It's lovely to join you guys. I'm going to ask you to bear with me this evening. I'm mum of two little people, and Dad is doing an absolutely sterling job this evening because in the UK it's bedtime at the moment. But my daughter's sick, so it's seemingly very complicated to get the two to bed. So if they're shouting in the background or I run away for a second, I'm sorry. That's what's going on. But I'm absolutely thrilled to join you. I've got some slides that I've popped together. Hang on, we've got almost got some slides that I've popped together. There we go, I think. Do feel free to unmute yourself and step in if you want to join the conversation or ask me something. You don't need to wait till the end if you want to stop me if anything needs clarifying. I want to talk to you a little bit about the journey that I've been on lately around trying to standardize measures around mental health. And having chatted to Alyssa, I understand this conversation that you guys have started having already, and challenges I think that Alyssa's realizing with her team and her work that you're facing over in Canada as well. So it was really reassuring to know that I'm not on my own trying to work this one out. I'm really lucky to work with a large team of fabulous people here in London. Collection of PhD students and research associates and colleagues that are lecturers and professors at the Institute of Psychiatry, Psychology and Neurosciences. This is some of our team. I have been over the last 5 years or so directing a national research network called SMARTN, which is a student mental health research network. And we've been looking to think about how we improve research into student mental health. And one of the directions that drew us was thinking about, well, how are elements of student mental health measured? Which, as we were sort of digging into that, led us on the start of a quest to sort of think, well, surely there needs to be some standardization in the measurements. And for me, with this project, it started with a piece of work with SMART and looking at measuring well-being in the student population. My work primarily is sort of non-clinical. I come at mental health from a public health perspective. I'm interested in asking what our institutional policies do to impact on students' mental health. How can the way we teach impact on student mental health? So then thinking about how we measure well-being felt particularly important, because this is sort of cutting across into a non-clinical space. Perhaps it's an outcome we can measure to understand how our less clinical or our non-clinical interventions or maybe policy changes might be impacting on students. So for this piece of work, it took the form of two parts. So we reviewed the literature to look at how well-being was being measured in the literature. And we also then consulted stakeholders across the sector for if they're thinking about well-being, mental well-being as an outcome measure, what should that include? What's important there? So this is all captured in a report that you can download from the Smarten website. But I just show this graph to you. This shows. Hang on, you probably need to step back a little bit. We were doing a Delphi approach with stakeholders across the sector, getting them to identify the outcomes that were important for well-being. And then we went back to the groups again and then again. And what you're getting here is the proportion of people identifying that this factor was relevant for understanding well-being. So these groups had already given us the list of factors: resilience, flourishing, emotional growth, and then we're endorsing these factors. This is a horrible graph and it's really messy, and I've really only put it on the screen to show you that if we're asking a stakeholder group about what's important for mental well-being, there's a whole host of stuff, and I'd like you to just note that the bars are all over the place. There's not a lot of agreement between stakeholders in terms of what well-being is, which is really a bit of a pickle for then what we're measuring when we're measuring well-being, because people have really different ideas about what that construct is, and yeah, they had different ideas about what the construct is. So what we tried to do in this project was then think about, well, can we develop some coherence across stakeholders? And we did, and it looks like I've managed to give you a graph that or a picture that just about makes sense, maybe. We've got the whole group here on the left, and then 4 subgroups across the right. So people working in student services, researchers and academics, students, and other stakeholders. So this might be university management, or leaders or other stakeholders that have an opinion around student mental health. And overall, people thought that social support was important, coping was important, eudaimonic and hedonic well-being were important, and self-belief. But that pattern isn't there universally across the stakeholder groups. And actually, interestingly, the group that's probably the most different is students, who have a different factor in there of sleep and work-life balance. So that was those were equally important for students. And they don't think self-belief is a thing that's so important. So I guess I'm trying to show you here 2 things that we can do a bit to try and cluster what people think's important, but remain concerned about the diversity that we get across stakeholder groups of how they're prioritizing different areas of well-being. And then I think, if I'm lucky, my next slide, what we then did was try to map those 5 areas against the measures that are currently being used in the literature to assess well-being. This is a summarized table. I think we found over 50 different measures being used to assess well-being, mental well-being in the student population. There were loads and loads of measures. And what we pulled out here were the measures that were used most commonly. And what we wanted to show with this is just that most of these measures only tap into a few areas, or even maybe just one area, hedonic well-being, that stakeholders thought were important when considering what well-being is. And I note at the top that so the WEMWebs and the GP core actually have measures that identify that map across all of these areas, which is promising. But then other scales are not working across sort of that full picture of what our stakeholders thought was important. So I just wanted to I wanted to start there to give you an example of my first start at kind of trying to piece together the challenges of thinking about how we standardize measures, and thinking about what different stakeholders have different opinions, different things matter. The existing literature has used really varied measures. And as you get into this, you start understanding that there isn't all that much consensus about what it is that we're supposed to be measuring. I'm just going to pause there and ask whether anyone wants me to clarify anything that I've said so far about well-being before I move on. You're all very polite. Okay. So the next piece of work that we did with Smarten was to think about, can we pull together guidance on how to measure well-being and mental health in university cohorts? So you're probably as familiar as I am with the... Oh, sorry. Yes, I'll step backwards. Yes, I should. Someone has asked in the chat, what is eudaimonic and hedonic well-being? It's a really good question and a really difficult one, given that for me at the moment it's 6 o'clock on a Friday evening. Very briefly, eudaimonic well-being is the kind of well-being sort of generally feeling good about life. It's striving for a purpose. It's finding meaning. It's the good life. It's yeah, maybe then it's helpful to compare to hedonic well-being is the things that make you happy right now. So going out for a party this evening might tick the box for me for hedonic well-being. That might be fun and lively and engaging, but hedonic well-being and eudaimonic well-being are really quite different. So the eudaimonic well-being might be that good for me this evening would be going for a run and building my overall fitness, so striving towards a good life. I hope that helps. I do find the distinction between the two quite tricky sometimes. So looking there again, measuring psychological well-being and mental health in university cohorts. We're very aware here in looking at that it would be really helpful if universities collected the similar kinds of data and were able to share that around student mental health. This is a really large population group. We don't have a great understanding of the factors that influence their mental health and well-being. So we thought we can't really tell universities or researchers across universities what to do, but we could put together some guidance. So what Smarten did was convened a series of workshops, it was sort of a year's worth of workshops with stakeholders across the sector, asking people to work towards trying to build a consensus for what would you like in a cohort study looking at student mental health. And I need to note here, I didn't do this work. This work was done by Dean Macmillan at the University of York, Professor Dean Macmillan and his team there. They've done really fantastic work here. But Dean starts by setting out 10 criteria that the stakeholder groups agreed on as being important for thinking about choosing measures to assess mental health. And remember that these are for cohort studies, so they're interested in looking at a non-clinical population, so people that aren't using services. This should be something that you could administer to all university students. So the groups agreed that the measures really need to have good psychometric properties. So that's looking at that rather basically, that's getting the stats right. Do these measures measure what we think they measure, and are they good at measuring it? Which I think is probably a basic foundation for using any measure. It felt it was important that they'd be sensitive to change. So some measures are better at picking up change than others. And if we're interested in looking at perhaps change over time, we need measures that are going to be sensitive to that. Then we get into things like acceptability. So are these measures acceptable to students? And so there perhaps we want to know whether there's been good consultation with students to understand what they think about the measures. Sort of a gold standard of that might be to do something called cognitive interviews, which is to sit down and ask students to walk you through what they're thinking as they're completing the questionnaire, and check that actually all of the items make sense to them and capture what they understand about the construct that's being measured. Then we could look at acceptability to other stakeholders, so other people that might be interested in looking at student well-being. Ideally, the measure might be designed for students, so particularly capturing the needs of that population, so designed specifically for that population. It should be designed for then a non-clinical population. If we're looking at using this outside of a clinical setting, it needs to be appropriate for use outside of the clinical setting. And then we thought it would be useful to be comparable to other data sets. And this is where you start getting into the drive for standardization, is that if we know there's lots of data being collected by our health service, that's our NHS, maybe it'd be useful to be using similar measures to them so that we can compare to data that they hold. Or we could look at comparability to university counselling services or wellbeing services. So what measures do they use? And again, we're just interested in whether we can compare. We agreed that these measures should be free to use and they should be brief to keep burden on participants as short as possible. Sorry, as limited as possible. I'll just give you an idea of where some of the work on this went. So Dean and his team then looked at a range of measures that were suggested and mapped them across these different areas. So to see whether how measures fitted with what sort of the requirements that the stakeholders had agreed were important. Here I've got a table up looking at some general measures of psychological symptoms, and the GHQ is a really common measure for looking at general mental health. And it's got good psychometric properties. It's sensitive to change. We don't know if it's acceptable to students. No one's tested that. Is it acceptable to other stakeholders? Not entirely sure. We know it wasn't designed for students, but it is good and was designed for use in non-clinical settings. But it's not comparable to other data sets used in the NHS or counselling services, and it's not free. Dean was putting together tables like this for measures of lots of different areas of psychological functioning to help people make decisions about which measures they might like to use. So we've got a similar one for psychological well-being. And then I wanted to look at this one for loneliness, which is actually an area that I'm doing a lot of work in. And I'm primarily doing a lot of work because we seem to have realized that we don't have very good measures for loneliness. So standardly, I think loneliness is measured by the revised UCLA 3-item scale. So should really just ask people, are you feeling lonely? I think there's been a lot of questions about whether this really captures what's going on and the complexity of loneliness. So as an overview of other work, I guess, that we've been doing for Smarten around standardization, which led me to work on another project with an organisation called TASO, who wanted to put together guidance for for student services staff, for people working in universities in a non-clinical space, guidance on how to evaluate their interventions. So I took all the work we'd done with Smarten and had a go at applying it here to put together some guidance for the sector. And then where I want to go next is saying that I've had a bit of a change of heart, or I'm significantly doubting the work that we're doing here. And I wanted to say this. I want to give you an example with a scale. We can look at the PHQ-9, which is the routinely. I put it up on the screen. Actually, it's there. This is a scale that is widely recommended to be used to measure depression. It's actually in the UK, it's mandatory from a number of our funders. So if you're funded by UK Research and Innovation, which is the government's funding, and you're doing anything on mental health, you have to use this scale. You can't use another measure of depression. And if you're funded by the Wellcome, I think they have the same rules. They want you to use this and not another measure of depression. So it's really being pushed very strongly. But I've been looking at that and then thinking back to the work I was doing on wellbeing and the extent to which the measures that we have of wellbeing capture what we understand or what stakeholders understand the construct to be. And I started doing some work with a colleague trying to think about whether the PHQ meets the needs of stakeholders, whether it meets our understanding of what depression is. At this point, I'm probably a bit late in the webinar to do a little bit more of an introduction to myself, but actually, you know what? I'm going to take down the slides, and then I can talk to you a bit more. I hope you've had a good look at that list. Maybe I'll have a pause there, have a look at the list, have a think about what items are there in terms of measuring depression, and then I'll take it down and chat to you without the slides on the screen. Okay. So, my research all looks at student mental health. And before I started my work at King's, I set up the charity Student Minds, which is the UK's student mental health charity. And I set up the charity Student Minds based on my own lived experience of mental health problems. I really struggled with my mental health as a teenager. I still struggled at university. And when I was at university, there was an opportunity to start to do a little bit more to think about, well, how can we support each other? Student Minds did a lot of peer support initially. But in my research, I've continued to really look at lived experience and try and understand the patient or service user perspective. So I've done some work with students with eating disorders, understanding their routes, navigating care systems. And I say all of that to set up, looking at the PHQ and understanding how it's measuring depression. I was working with a colleague of mine, Dr. Armstrong, who also talks about his own lived experience. And we were thinking about our experiences of depression and whether the PHQ-9 was measuring what we understood as depression. And we felt a bit ranty about this push for all of us to need to be using the PHQ. You know, I've got a solution here. I'm just going to pop the PHQ in the chat for you so you can see it. And I went on a bit of a history mission to understand how the PHQ was developed. I think for my history mission to make sense, I first need to tell you a little bit about what good practice looks like from developing a new scale. And I'm particularly familiar with this because I'm currently trying to develop a new scale to understand students' expectations for social life at university. And we've been busy trying to develop a new scale for measuring this. And what you're supposed to do if you want to develop a new scale is go away and read the literature in the area and think about what are the domains that we're measuring here? What is this construct that we're measuring? And then you should go and do some work with stakeholders in the space. So for me, that would be going and interviewing students and get their thoughts on what this construct is, and then try and map their thoughts against the literature and develop some domains and some items. And then you might take all of your items out to the stakeholder group that you're working with and get them to test the questions. Say, do these items work? Do you understand them? What do you think they're measuring? Do they make sense to you? And I can tell you from when we were doing this in our scale development, we rewrote almost every single item because students were pulling them apart and saying, I don't get this and I don't get that bit. And then we might put them in a survey and administer the survey to the population group that's going to be using this scale, and see how well all the items perform. And then we might look at whether there's factors in there, and think about how the items cluster together. And then we might test whether the scale's reliable. So if we test it today, will we get the same result as if we test it tomorrow? If I test half of it, will I get the same result if I test the other half? So we can play around statistically and see whether it's sort of consistent, the scale's consistent within itself. And then we can see whether it's valid. So does it measure what we think it's measuring? So we might do that by looking at whether scores on this new scale correlate with other related scales that we already have, or maybe does it predict interesting things in the future that are relevant? So those are all the kinds of things that we might look at in terms of developing a scale. And I explain that to say, well, I did this, but to give you context to the history trip that I went on of trying to work out, so this PHQ-9 that we all have to use to measure depression, Where did it come from? So the PHQ-9 was derived from a measure that existed before that called the Prime MD, which was an interview schedule for GPs, for physicians, for family doctors to use to assess whether or not somebody had a psychiatric condition. And physicians, well, there were two problems. Physicians were complaining that this took quite a long time to do, and if they had a busy clinic, they didn't have time to be doing this. And pharmaceutical companies were puzzled that there weren't so many prescriptions being written for antidepressants, that depression was being underdiagnosed and therefore undertreated with antidepressants. So there was a drive to improve detection of depression in the public health setting, so in primary care, in GPs, in physicians' offices, I'm being highly cynical here, but to increase prescription of antidepressants. The research my cynicism is underlined by the fact that all the research to develop the PHQ-9 was funded by Pfizer. And the goal for the development of the PHQ was to make it quicker and easier for physicians to test whether someone had depression. Rather sadly in this is that the complaint was that the Prime MD took about 8 minutes to administer, and they needed something that took less than a minute, which I think is rather sad, that really this scale that we're using to understand depression was developed from a drive to reduce the contact, I guess, between the physician and a patient. Now, the scale itself was developed by taking the interview schedule and turning into items. There were apparently there was a phase in the development which included interviews with people with depression to understand how they thought the items were working, which is great, and we ought to see that. What's highly problematic is that's never been published. None of the data from that development phase is published. The only mention of it is in a stats paper that says before this scale was tested statistically, some patients were consulted, full stop. So then when they tested the PHQ-9, what they were looking for in the study to testing whether it worked or not, the main outcomes were, did it reduce the amount of time? Main outcomes they were looking for was, did it reduce the amount of time that the physician spent identifying depression? And did it allow more cases of depression to be identified? And it did. It improved identification of depression. But the original authors noted that there seemed to be a cost of administering this scale, which was that the doctor's engagement with the patient was reduced, leading to a less detailed and comprehensive understanding of the patient, and the relationship, reducing the relationship, which had a knock-on effect of reducing therapeutic support for the patient. So they found that while the physicians got better at identifying depression, they were less likely to refer the patient on for further help. And the speculation there is that because they didn't engage with the patient, they didn't develop a therapeutic relationship to start to understand what was going on for the patient. And Alyssa tells me that that her team, and perhaps with you, have been starting to have some conversations about I guess the gap between measuring mental health and the stories that we hold around this. And I'd invite you to have a look at the PHQ items with me. My reflection from my experience with depression would be that for any of these items, it would be kind of well, it sort of depends on what hour of the day you're asking me, what day of the week you're asking me, and what topic it is that we're thinking about. So I'm feeling bad about myself, or a failure that I've let myself down or let my family down. well, maybe in some areas of life, but not in others. And it might be catastrophic in some areas and maybe not at all for others. And trouble concentrating on things, or maybe trouble concentrating on some things, but not other things. And my wonderful colleague, Dr. Armstrong, elaborates on that to say, but this feels very strange because there's got to be a bit more to depression than just this binary feeling low, not feeling low. And his reflection on having to fill this in and again in a clinical setting was that nobody was terribly interested in what was actually going on in his life or helping him understand why he was feeling depressed and what was contributing to the depression. Just this repeated focus on, well, how are you feeling? So if we look at that, it gets you to focus in on, I'm feeling down, depressed, or hopeless, or I have little interest in doing things, without an opportunity to think about why are you feeling down? What are the factors that are contributing to that? What are the factors that are contributing to that lack of interest? And I appreciate that I'm possibly asking for something rather complicated there, but it does feel like somewhere along the line we've reduced the complexity of life and the complexity of mental health down into a list of items precisely for the purpose that they're quick and easy to fill in and don't have to lead to difficult conversations with people. When I think I thought that the crux of solving mental health might sit in having difficult conversations and the time and space to have them. Alyssa, on that note, I'm starting to become conscious that I might be rambling, and I think I should stop rambling, and I'd love to hear what your audience think of this. And I'm keen to take questions, but also open up discussion.
I don't think you're rambling because I love this conversation, and as you said, I'll put my video back on. We have been having conversations about that stories piece and how what's missing when we talk about measurement, and I think it kind of came from an anecdotal story of having that conversation with a doctor, and what is when you go in and you have that story, and then sometimes you're given those tools, then how there sort of becomes that space that shifts things and shifts the story that you had because of that sort of that piece in the middle there between that engagement and that interaction with the doctor, as you mentioned just recently.
Just Alyssa, before you open it up, I'd just love to ask your thoughts on that. If I think we can both identify that happens and feels uncomfortable, but to me it feels a million times worse to know and appreciate that was intentional. That's baked into the system. That's why this was designed, to stop the physicians having to deal with this complexity, or stop them having to have uncomfortable conversations that might be difficult to have in a busy clinic.
And then I think I don't have anything to add except for maybe further complexity in that. Then when we add that standardization, we know from the research perspective and from the and all of this, like having those data sets and being able to not only for the research side but also for the patient side. Like I myself like to be able to in my care have to be able to see sort of a graph of wellness and being able to chart things, and these types of tools do allow us to have more of that. But again, how does that interact with that complexity and that story piece? And I would say I don't have I don't have answers, but I think this is what we're also trying to talk a little bit more about, and also trying to think about, I guess, what is an alternative, and what does it look like to be able to think about still having sort of standards and measures, and I think thinking of standards also in terms of quality of care, that, and how do we measure quality of care, and it gets further complex. Hey,
Alyssa, there's something that I found particularly puzzling when I did my homework on the PHQ-9, in that the original version of it contained an item which just speaks to what you've just said of how do we assess whether things are helpful, whether interventions are helpful.
Yeah.
And the item was, how difficult have these problems made it for you to do your work, take care of things at home, or get along with other people? So it's not measuring how you're feeling or anything. It's just saying, look, we've looked at all of these problems. How difficult have they made life for you? And the original publications on this noted that that item alone was the strongest predictor of whether a clinical diagnosis was given. That item was the best predictor of whether a psychiatrist running a similar assessment would decide you have depression. So how difficult have these problems made basically day-to-day life
Mhm.
for you? That doesn't feature in today's PHQ that gets widely used. It doesn't, and I've just found that interesting in that I sometimes wonder whether there's a simplicity in evaluating whether an intervention's worked, which is just, has it made life easier for you? Does life feel easier than it was before you did this intervention?
I think it's an excellent point. That's an excellent point. I see some hands are going up also. Are you okay if I open it up
Absolutely,
to
please
conversation
do.
and
Yeah,
questions?
please
And I
do.
think I can allow people to talk. So for instance, Jay, I see that you have your hand raised. I can use you as an example and give you the mic and allow you to talk if you want to ask your own question. Go ahead.
Thank you. Can you hear me?
Yes, we can.
Okay, this is Zoom gets fancier and fancier. First of all, thank you so much, Nicola, for a wonderful presentation and for problematizing so much of the things that we sometimes take kind of as routine and for granted. I wanted to maybe ask you to expand on something that, and just as background, I'm a clinician scientist in Montreal and I'm affiliated with this Catalyst Grant, so really appreciate you coming and presenting here. I'm going to ask you to maybe expand on something that you alluded to and touched on, which is, there is the critique, of course, of the items and the constructs that an instrument like the PHQ-9 is tackling. But at a different level, one of the phenomena that's happening is that, again, as you alluded to, research funding agencies are really arriving at standardizing or a desire to get people to standardize around at least some instruments. And the PHQ-9 is a very good example of one that's been kind of asked for by a number of agencies. And this happens now, not just with individual agencies, but in agreements or consensus recommendations across agencies. So there's a whole youth mental health committee establishing recommendations, common measures across, whether it's NIH, Wellcome Trust, NIHR, etc., even at the international level. And so I'm curious about how you or one might, with the concerns you have, might respond to this push for harmonization or common measures. Because, I think there's an argument for it, but there's also an argument against it. And I'm curious if you might be willing or able to expand on the argument against it, or at least wisdom about it for us.
Do you know, I don't, this is tricky because I don't have a strong push against it. If we're going to measure depression, it really is frustrating if everybody uses a different measure. I completely see the logic.
So that's the argument for it, right?
Yeah, I completely see that logic. And then I've been part of a growing number of systematic reviews into the literature evaluating things in the area of student mental health. And the recommendation at the end of every systematic review is, please, can we have a little bit more standardization in the measures that we're using? Because this is impossible. We cannot synthesize data when everybody's using different outcome measures. And I have to say, one of the reasons why I feel particularly agnostic about whether standardization should happen is that I think a lot of these measures are all as bad as each other. I've picked out the PHQ-9, and I think its history is particularly troubling. But other measures of depression similarly reduce the experience of depression down to, are you feeling down, basically? Well, and I mean, there's a range of symptoms here, but it's a focus on how you're feeling, as opposed to allowing space or opportunity to think about what's going on there, what that's about, what's driving that, or allowing the flexibility to say you might be feeling some things about some stuff and some things about other stuff and different times of day, and it might vary, and allowing space for that variability. Sorry, that probably wasn't really the answer that you're looking for, but I don't know how that sits with you.
No, I really appreciate it, and particularly the acknowledgement that, and we should be how do I put this? Ambivalence is sometimes a sign of maturity, right? In the sense that you can see arguments for or against or both.
Mhm.
And, if that is something we can acknowledge on all sides, then maybe we're actually further along than we were a year or two ago or 5 years ago. So thank you.
Alyssa, I can't see if there are other people hunting for or looking to ask a question. I can't. Can I see that?
We have an if you can see the attendees piece, but I'll ask folks if they want to write in the chat. If you don't have to, you can just write a question in the chat. You don't have to go on voice. I thought I'd put Jay on the spot to ask his question. But please feel free to write in the chat if you do have a question, or you can raise your hand. Crickets, perhaps. We'll wait a moment.
I've almost, if I might be naughty and then ask your audience a question about.
No, go ahead.
About whether I guess it would be whether the history of the PHQ surprised anybody. Would you expect it to have been developed in a different way, or actually, I guess if I was playing devil's advocate to myself, it would be to say, well, it's sort of just derived from what psychiatrists felt was worth asking patients about their mental health, and it's just been simplified and simplified and simplified. And maybe that's okay.
Wonder if
Maybe
people
that's okay.
wait back. People can write into the chat. They can respond to you. I think one of the other things that we did talk about in our group, kind of thinking about different measures, was just maybe sometimes why we kind of maybe can't pair some of the questions that feel a little bit more like the PHQ-9, and they feel a little bit more I guess cut and dry, with some of the questions that allow for more storytelling and allow for more of that piece. Like, are there opportunities to pull to sort of combine the tools to be measures that are more qualitative and quantitative in nature, versus I think sometimes we are using more of just like the numbers scale, and maybe if like what are the opportunities to bridge that. So that is a conversation we've also had in our smaller group.
The statisticians I work with would weep. They go, you can't bring in qualitative data to our surveys. I'm sorry, we can't cope with it. I'm a mixed methods researcher, and I have a huge amount of respect for both approaches. And I think sometimes where the quant approaches feel most uncomfortable, it's because perhaps we don't have a general conviction that these are measuring what we think they're measuring, but like it's not really doing what it says on the tin. To which really good qualitative work could help us address that. We could go back to basic principles and check, what is this construct that we're measuring? That is in effect what we're doing at the moment, looking at loneliness for young people. So in the UK, I don't know if you've got similar data in Canada, I wouldn't be surprised, but everybody's suddenly become very surprised that young adults are the loneliest group of our society. Loneliness was always thought to be something that affected old people. And now we've seen where young adults seem to be the loneliest. And to me, something feels a bit odd in that, of that maybe, but maybe loneliness for young adults as they're reporting it, although it might look the same on the tin, is actually very different to the loneliness for older adults, and that we might need to be measuring something a bit differently. So we've recognized, or at least we've convinced funders that perhaps we need to recognize that that maybe we don't really understand what loneliness is for emerging adults. And so when we ask this 3-item questionnaire to assess their loneliness, we're not entirely convinced that we know what that's measuring. And so there's a number of projects in the UK that have gone back to the drawing board to do extensive qualitative work with young adults to understand what they mean by loneliness. What is loneliness for them? My bit of the project that I'm working on is looking at developing some measures specifically for students and thinking about elements of the student experience. But there's another team in the UK led by Dr. Jennifer Lau that's gone back to basic principles to develop a scale specifically to look at loneliness for young adults. Sorry, Alyssa, that was a long answer to a simple question, but I think going back to principles rather than tagging qualitative bits into a quant survey would be to say, okay, is there something fundamental that we're not happy with about how this scale's working? And then to acknowledge that and say, okay, well, we need to go back and understand what is it that we're trying to measure here.
Thank you so much. No, I appreciate the answer. Long is welcomed. And I see, Sarah, that you have a hand up, and I'm gonna allow you to talk, so you can go ahead.
Is it working?
Yes.
I'm gonna allow you to talk.
I know that's what the button says. It says allow to talk, and now it says talking permitted.
Oh, thank you so much. No, I guess what was I gonna say? It went in a bit of a different direction than when I put my hand out. I was just gonna say, okay, so I've had my career has largely been in the lived experience world and the youth advocacy world, and I have a qualitative background, and I guess I very much appreciate and sort of have said similar things and felt similar ways about how these scales are not at all capturing need or experience, and that we need so much more. So thank you for this conversation. I think it's interesting and very needed. And then I guess I'll just say that the things that I find myself not struggling with, but questioning would be that, I guess I've worked in I have 2 points. So my first is in a couple different places from an advocacy perspective, where we're saying like young people need more services, or if I've worked with different post-secondary institutions and they've been like, I don't know if we need a counselor here, or if we need mental health services more than our volunteer peer support program or whatever. So oftentimes like a very quick and dirty scale that says, actually, no, like 70% of your kids have a very high distress level on the K10 or PHQ-9 or whatever, is probably the only advocacy tool I've been able to use that's effective, like a quick and dirty, like there is need here and we need services. And then on the other side of that, I would say at Kids Help Phone, for example, there was a lot of resistance to putting in outcome measures and surveys because they're, kids are calling in crisis and they're in need. But we had choices to make internally on triage and on funneling kids to different services based on need. And the quicker and dirtier, frankly, the better, because we had to be like, who needs this? Like, who needs the crisis counselor versus a counselor who might be better suited in different services? So in those 2 examples, I see a need for like the quickest possible just to measure like a need is here, which might be where we're at in the system because it's been denied for so long. But I guess my question is, how do you balance like, absolutely, these don't capture the experience of struggling with various mental health problems or illnesses. And certainly they're not helping understand like what's going on for a young person and guiding treatment, but they're also highly necessary for sometimes saying like there is a need here or capturing need. And I don't know how to balance those different things. And I'm just wondering if you or anyone has a comment on that.
I don't have an answer, Sarah. I can give you I can give you my perspective, but it's only that, and it's my perspective from my own experience rather than I mean, I'm cheeky. I sit in this research role. I don't have to get stuck into the ins and outs of service provision. And I think I have retreated from my frontline work at Student Minds in part to the research place because it feels like it's an endless battle doing the advocacy work. If I'm being kinder to myself, it's because I've hoped that if we get better data, we can do the advocacy work becomes easier. I get so there's something in the quick and dirty. So let me say first of all, Sarah, I completely hear what you're saying and the need and the value of the quick and dirty, and you've articulated so well how and why it's really useful. So I hear that, and then forgive me then for saying that I think it also is problematic. I think it is also problematic. And if I'm drawing from my own experience, around the age of 13, 14, I was diagnosed with anorexia, and that was done in a very, well, you have these symptoms. And then from that diagnosis onwards, most of my mental health was measured in terms of a weighing scale, which I don't know if anybody out there resonates with that experience, but weighing scale didn't really tell anybody very much about what was going on in my head. And if there's any psychiatrists or psychologists there, you'll know that there's a bit of a disconnect between what the weighing scale says and what's going on in someone's mind. But I might have had anorexia, but first and foremost, I was really struggling with what was going on in my day-to-day life. And that got erased with the diagnosis. The diagnosis became first and foremost, and there was a focus then on the elements of the symptoms that tied to that diagnosis, above and beyond what I've had in my experience, above and beyond the wider life experience that was going on that led those symptoms to present. And I guess that's where I get uncomfortable with, I don't know, for me, was it helpful to say I was anorexic, or would it have been better to say I was really struggling with life? And we could have looked at that. And I think very often when young people are in acute distress, we're ending up labeling that as depression or anxiety and failing to stop and look at what's the cause of that distress. And I think we're working often with something closer to a biomedical model of mental health that assumes that distress might sit within the individual. And I think most of the time, the distress that we pick up that in the individual is there being caused by factors in their immediate environment, in their relationships, in their family, or in the society, in the immediate community around them. And there you're measuring what's going on for the individual, but actually you're measuring what's going on for that community and the society. It doesn't, I don't think it helps to triage if I tell you that. And I don't think it might, I think it could help to change the positioning on advocacy work. But I fully recognize that we're not good at the moment at measuring or seeing or capturing community well-being, how well communities are doing rather than the individual. But I think, Sarah, that would be where my nervousness comes in saying, yes, let's just stick with what we currently do because it is useful.
Thank you for that.
That's okay.
Thank you. And I think that I'll just offer a last comment about the question that you had mentioned in the HQ9 that I think you mentioned that you saw in another version, and about is this affecting like the quality of life, or I'm not sure how the exact wording was.
I'll pop it in the chat for you. There you go.
Yeah, how difficult have these problems made it for you to do work or take care of things at home or get along with other people? And I think that's even just that question kind of is one of the things that to add another little struggle at the end of this conversation that we talked about in a smaller group with folks, mostly folks with lived experience, where folks said, you know, there are sometimes questions on the survey or on the measure that made me reflect and think, oh wow, I didn't realize how bad things were. I didn't like, and I think that's a question that resonated with me. And like, I would maybe read that question having gone into a service and be like, oh, actually, yeah, this is making like I'm having problems with doing my work, or I'm having problems at home. And I didn't realize that all these things had added up to that. So I would just say to further like to the things that resonate with me. And I think that we've kind of talked about in our smaller group is sometimes there are questions that can and be included in measures that do help you yourself as the patient be able to realize, oh, actually, I am feeling this way, or I give language to something. So I think there's, you know, still trying to find those balances of how do we use tools and diagnosis and also not, I guess, continue to continue to widen that gap of engagement between the patient and the person. I don't think we want to go any quicker. I think we need to think about how our system can allow for those for better relationships to foster and be supported. Thank you so much.
Thank you, Alyssa. Thank you guys for listening and for the lovely questions. Thank you, Sarah. Thank you, Jay.
Okay, well, I know that you we're at the hour. I know you have it's the evening for you and you have a sick daughter. I hope your daughter's feeling better soon. I hope to chat with you sooner than later. Maybe we don't need to wait till the next IYMH. But I also hope to see you in Canada next year, maybe. It would be great to see
I
you.
hope so. I hope so. Yeah.
Take
Thank
care,
you all.
Nicola.
Take care. Bye
Take
bye.
care. Thank you.